So fungal uveitis, the first one is presumed ocular histoplasmosis syndrome, POHS. Histoplasma capsulatum infection. It occurs following inhalation of the yeast. Yeast form of this dimorphic fungus lead to the systemic mycosis, histoplasmosis. The pulmonary involvement is the most common feature. It is common in AIDS. POHS is relatively common in areas of endemic histoplasmosis. For example, the Mississippi River Valley in the USA. Causality has never been definitively confirmed, but over 90% react positively to the histoplasmin testing. It is believed that eye disease represents an immune-mediated response to microbial antigen rather than immediate damage due to active infection. The ocular features 60% have bilateral signs. Presentation. POHS is usually asymptomatic unless macular choroidal neovascularization supervenes. Signs may be discovered as a routine eye examination. There is classic triad in which first one is multiple white atrophic chorioretinal histospots about 200 micrometer in diameter. These are the spots. These are the chorioretinal histospots. Number second the triad is peripapillary atrophy. This is peripapillary atrophy. Number third, vitritis is absent. Linear mid-peripheral scars. Linear mid-peripheral scars also occur. Here you can see linear mid-peripheral scars. So this is the triad. Choroidal neovascularization, CNV, is a late manifestation occurring in less than 5% of the affected eyes. It is usually associated with pre-existing macular histospot. Associated with pre-existing macular histospots. Associated subretinal fluid and hemorrhage lead to a fall in vision. So this is choroidal neovascularization. The fovea shows focal area of edema and a few small hemorrhages. And this is fluorescein angiography. A arterial page shows choroidal neovascular membrane just above the fovea. Acute chorioretinitis is almost always asymptomatic and rarely identified, but discrete oval round whitish lesions of less than 400 micrometer in diameter that may develop into classic punch-out histospots have been confirmed. Skin testing is no longer undertaken. HLA testing, HLA-B27, DRW2, serological testing, but they are usually negative in the absence of systemic mycosis. FA and OCT when the CNV is suspected. Spontaneous regression of CNV may occasionally occur. Without treatment, 60% of eyes have final visual acuity of less than 6/60. Intravitreal antivascular endothelial growth factor, anti-VEGF injection for the CNV, Amsler grid testing of the fellow eye at least weekly. particularly if a macular histospot is present. Then there is 25% risk of CNV. Any role for antioxidant supplement is undefined. So that was presumed ocular histoplasmosis syndrome. Now, Pneumocystis choroiditis. The fungus Pneumocystis cerevisiae. It is a pulmonary commensal. It is a major cause of mortality in uncontrolled AIDS. Systemic antimicrobial prophylaxis has replaced pulmonary only preventive treatment with inhaled pentamidine, and along with immune reconstruction has dramatically reduced the incidence of Pneumocystis choroiditis. Multiple slowly progressive deep round yellow deep round orange lesions, commonly bilateral, are characteristic. There is minimal vitritis and visual loss is often negligible. This is a large coalescent lesion, and these are multifocal choroidal lesions. So there is minimal vitritis. Visual loss is negligible. Cryptococcal choroiditis. Cryptococcus neoformans. It is a dimorphic yeast, enters the body through inhalation and can spread to the eye in the bloodstream or from the CNS via the optic nerve. As with pneumocystosis, cryptococcosis was formerly responsible for much morbidity. Clinically significant infection is now much less common since the advent of more effective therapy for AIDS. Ocular involvement may occur directly, for example, multifocal choroiditis. This is multifocal choroiditis, cryptococcal choroiditis, with vasculitis, and exudates are more commonly indirectly with papilledema and ocular motility dysfunction. Endogenous Candida endophthalmitis. Candida, usually the commensal Candida albicans, can be introduced into the eye from the external environment by trauma or surgery, or can spread from fungal keratitis. But endogenous infection is an important alternative route. Risk factors for metastatic spread include intravenous drug abuse, septic focus associated with an indwelling catheter, chronic lung disease such as cystic fibrosis, general debilitating and diabetes, which is relatively uncommon in AIDS. Clinical features. The presentation. Systemic candidiasis may already have been diagnosed. Up to a third of patients with untreated candidemia will develop ocular involvement. Peripheral fundus lesions may cause little or no visual disturbance, while central lesions or severe vitritis will manifest earlier. Progression is typically much slower than bacterial endophthalmitis. Bilateral involvement is common. Anterior uveitis is uncommon or mild in early disease but may become prominent later. Vitritis may be marked with this is vitritis, severe vitritis with fluffy cotton ball. These are cotton ball colonies or string of pearl colonies, sometimes progressing to abscess formation. Chorioretinitis. One or more small creamy white lesions with overlying vitritis. Retinal necrosis may lead to retinal detachment with severe proliferative vitreoretinopathy. This shows focal chorioretinitis and this is retinal necrosis. Vitreous biopsy using a vitreous cutter to identify the organism and identify sensitivities. Systemic investigations, blood and urine cultures. Treatment, antifungal treatment. chosen with local microbiological specialist. Advice: intravenous amphotericin B is the treatment in combination with oral fluocytosine, but resistance is a concern. Voriconazole orally or intravenously has a broad spectrum of antifungal action with low reported resistance, high ocular penetration. Adjunctive intravitreal treatment may be given 100 microgram in 0.1 ml with serial injection probably needed. Pars plana vitrectomy should be considered at an early stage, especially for severe or unresponsive disease, as well as providing a substantial culture specimen. It reduces fungal and antigen load, facilitates therapeutic agent penetration, and clears the ocular media. Aspergillus and ophthalmitis. Aspergillus species are common environmental fungi but cause disease in humans less commonly than Candida. Spores undergo airborne spread, and risk factors for infection include intravenous drug abuse, chronic lung disease, organ transplantation, blood disorders, neutropenia, iridocyclitis, and vitritis are common. Yellowish retinal and subretinal infiltrates tends toward macular involvement at an earlier stage than Candida. Disease progresses more rapidly and visual outcome is often worse. Occlusive retinal vasculitis is common. Stomach assessment is critical. Endocarditis is a particular risk. Investigation and treatment are similar to that of Candida and ophthalmitis.